what is the youngest patient you've seen come in with bowel cancer?
Probably 18. He had a very rare type of bowel cancer. It's called carcinoid cancer of the appendix. You know the ready-made meals that you just get from Asda and Tesco and just put in the microwave? Biggest culprit.
What?
Yeah, but there's definitely something in the food. Your gut has its own nervous system.
I thought, if you have the sugar-free Fanta, it's fine. Can you give us the 3 warning signs for colon cancer?
If you have cancer, you have these.
What can I do to stop myself from getting bowel cancer?
Stage 4 cancer means it's spread to distant organs.
What is the link between, low fiber and bowel cancer?
Lentils, black beans, but then also plantain.
Does sugar have a part to play in this rise in colon cancer as well? If you had 3 chances to live, and you're a surgeon, what is one thing you're going to do every single day, to be healthy? Hello and welcome to EZE Speaks. I'm your host, Francesca Ezenolim, and today we have a very special guest. He is an NHS General Surgical Registrar, specialised in the upper GI tract, and he's currently pursuing a PhD in new medical advancements. So today we're discussing the rising rates of bowel cancer and highlighting the key factors contributing to this trend among young people. Welcome to the show, Dr. Paul.
Hello. Nice to meet you.
Thank you so much for coming on.
Thanks for having me, man.
How are you feeling?
Yeah, I'm okay.
Good.
Feeling relaxed. You've got a nice setup here.
Thank you. Thank you very much.
Made me feel very welcome. So
Yeah, I'm glad. Tell us a bit more about you. Who is Dr. Paul?
So as you mentioned before, I'm a general surgery registrar. A registrar is probably what not a lot of people know it as. I think most people call it a resident. So that's what you call it in America, right?
Yeah.
So it's the latter stages of your training before you become a consultant. I do upper GI surgery for my day-to-day practice, and I do a bit of emergency general surgery as well.
Yeah.
And you mentioned that I'm currently pursuing a PhD, which is true. Pursuing a PhD in trying to, basically what we're trying to do is determine things like cancer, so bowel cancer specifically, from a breath test. So at the moment, if you wanted to detect cancer, you'd have to go into the hospital, get different blood tests, maybe do a bit of like screening work, so colonoscopies and stuff like that.
Yeah.
Whereas what we're trying to do is reduce the amount of steps taken before you can actually, reduce the amount of steps before the person finds out that they have cancer. And we're trying to develop a breath test. So you go into hospital or to a GP, blow into this device, and it will read like a change in your microbiome. And that'll be like, oh, this pattern looks like cancer.
Wow.
Yeah, and so it's at the very early stages, and we're trying to get funding for it. So,
well, I really hope you do, because I think we need that, given the rates of bowel cancer are rising anyways in young people. So that sounds very, very good. Yeah.
Thanks.
Is there anything else you also do on the side at all?
Yeah, so I'm part of a cohort of trainees. We're a pilot group of trainees actually, who are involved in being trained up to use some of the Da Vinci robots to perform surgery on patients. So they're training us on how to use their robots to basically perform keyhole surgery, but from a remote station. So rather than being at the patient, you're at a remote site.
Somewhere else.
Yeah, at the moment, because of safety reasons, we're still in the room.
Yeah.
But the whole premise would be you'd be in another room or in anher,
That's insane. Do you ever have any concerns that AI is going to take over your job as a surgeon?
No, there are 2 reasons why.
Okay.
So the first reason is because last year I had a side gig working for OpenAI. And what they wanted me to do, along with a few other doctors, was to basically train their language models to help people who are basically at home or the layman to, answer health queries. Yeah. And as I was doing that and going through the different answers that the language models were given, there was just so many inaccuracies and errors. Now, it is improving over time, but what it doesn't take into account is that everybody's unique.
Yeah.
And by everyone being unique, it's, even though there is there's a certain model or stereotype in terms of your anatomy, for example. So I do surgery. Yeah. Everyone's body is meant to look a certain way inside. It's never the same.
It's never the same.
Everybody's different, right? So if you look at even if you took every single palm tree, right, the way the branches are going to come out is different. Yeah. The same way if you look in the human body, the way the blood supply is going to be, for example, to the liver is always different. In fact, 60% of the time, it's different.
It's different.
So I'm doing a gallbladder operation. I'm always like, where's the hepatic artery here? Oh, it's not here. Oh, where is it?
Yeah.
And I'm looking for it. And so the robot isn't able to take into account, that it can change and where it's going to change to. The robot is going to take into account, like, this is where it's meant to be. And, you know, if there is something here, I'm going to cut it, even if it's not the artery.
And that's insane.
And that's insane, right? Because what if again cut something quite serious?
Yeah.
So I'm not worried in terms, at least not in the next 50 years, because there's still so much that needs to happen for these robots to be capable. I don't think they have the sort of higher order reasoning to be like, this shouldn't be cut or this should be cut. And one thing that I take from a book called, there's a guy called Moshe Sheen who wrote a book called something about surgery, The Good Surgeon. And he says the best surgeons are the ones, not the ones who know how to operate or know how to operate well, but it's the ones who know when not to operate. And so if you create an AI model or AI robot for operating, it's just going to do what it's directed to do. It's going to operate, it's going to reason information and operate and reason information and operate. Whereas the best surgeons actually, they know that you don't actually always need to do that.
Yeah.
You need to make a more critical decision and only intervene when you need to.
Yeah, and then a robot's just not going to do that.
Not yet, no.
England has experienced the fourth fastest rise in bowel cancer in under 50s. So in any other country in Europe, England is, the fourth fastest rise in bowel cancer. So that's quite a lot. Does that kind of surprise you as a doctor that we're having, this rise in bowel cancer right now?
Overall, no. As a doctor, with the information I have, I would say but in my workplace, every time I do get a patient who comes in who's under 50 with cancer, it does surprise me. Right? I look at the patient, I'm like, oh wow, that's so young. But in terms of from what I know as to the risk factors to why people get cancer, it kind of makes sense, right? When you look at all the associated risk factors for cancer. So the general ones being like things like obesity, smoking, the kind of foods we eat, sedentary lifestyle. That's more prevalent today than it was like before. So if they're all risk factors, it makes sense that, okay, bowel cancer will be like detected a lot younger in patients, or at least presented a lot younger in patients. But it's still surprising. At least it's still saddening and alarming. Right?
100%. What is the youngest patient you've seen come in with bowel cancer?
So I'll preface it with, you've got the genetic cancers, right?
Yeah.
And that accounts for maybe 10% of cancers, that bowel cancers.
Yeah.
So with the genetic ones, they're always going to present young. So you're going to exclude that. And you're going to look at the rest of the 90% of people who present bowel cancers. I would say the youngest that I've had from that cohort is probably 18, right? It was really young. This is when I used to work in Liverpool. And, he had a very rare type of bowel cancer. It's called carcinoid cancer of the appendix. But by the time he came to us with a diagnosis of suspected appendicitis, I think it had already spread to like his liver and his lungs. And so he wasn't curable. But his case was very rare. I think the average young age is usually around 36 to 40.
Yeah. I'm seeing a lot of people on TikTok, talking about bowel cancer. I'm seeing patients as young as 26, 30. So it's quite concerning. And that's a lot of them are in America, but even still, it's still very concerning. And a lot of the research nowadays is focusing on that. A lot of the foods we're eating is affecting our risk. What is the link between the processed foods and bowel cancer?
So I guess one way to look at it is your gut is its own vital organ. And, the term trust your gut doesn't just come from a colloquial saying. Your gut has its own nervous system and it has its own immune system as well, right?
Yeah.
So that means those things have to kind of be taken into account when you think about how it's treated. If you look at maybe non-Western societies and you look at African societies, the incidence of colorectal cancer, for example, is low compared to Western societies. And what is one of the common differences is the type of food we eat. The type of food we eat, I think here in the West, you've got something called ultra-processed food.
Okay.
Right? America specifically. Right? America is just crazy for ultra-processed food. And ultra-processed food is stuff that is high in sugar sweeteners, very low nutrients, right? No nutrients at all. And maybe what's called saturated fats, a lot of saturated fats, right? And the whole premise of that is it's not good for your gut. It doesn't help your gut at all. So your gut takes in this food and, it's not able to really take energy from this food because your gut needs energy itself. And in doing so, these foods can produce like oxidants that can damage your gut all over time, you damage the gut wall, you start to form like polyps and things and adenomas and things.
Yeah.
And these are the precursors for all cancers of the gut. And, you know, I think we were talking about a study earlier, right? And there's a study by Harvard, right? And they've taken 30,000, I think, women who worked in healthcare, and they've started from the year 1989. And what they've done is they've recorded all the types of food they've eaten every 4 years.
Okay.
Right?
Yeah.
And over the course of, I believe, 24 years or so, from 1989 till when that study ended, they looked at the healthcare professionals who ate ultra-processed food at high intake and maybe like 4 times a day, compared to those who took ultra-processed foods like maybe 3 times a week.
Yeah.
And the difference in the detection, or actually the incidence of colorectal cancer is like 45%. So that's almost half, right?
Yeah.
Exactly. So it's like, there's definitely a correlational link. You can't actually say this causes it, but there's definitely something in the food that is actually leading or at least contributing factor to, okay, people are getting colorectal cancer. And I think if you want to know what ultra processed foods are, it's, you know, it's stuff like Fanta. It's like your I'm a sucker for stuff like crunching up cornflakes, but that counts. That counts as well.
That's crazy. Even and a lot of like microwave meals as well. They do.
That's the biggest culprit. The biggest culprit is the the ready-made meals that you just get from Asda and Tesco and just put in the microwave. Biggest culprit.
What?
Yeah, because they have preservatives and additives to try and keep them,
it for longer.
Keep the use by date a bit longer. So
so with Fanta, I thought, you know, if you have the sugar-free Fanta, it's fine because at least it's sugar-free.
It's sugar-free, but has it got corn syrup in it? Which is another processed type of sweetener. So and you see that more in America. So a lot of the fizzy drinks and cordial type of drinks, they're rather than having sugar in them, they'll put corn syrup in them. And corn syrup is a great substitute because it's cheaper to make, but actually it has zero nutritional benefit to the human body. And so the more we eat these things and drink these things, then I think, you know, there is some type of link to our gut just saying, no, actually, you know, what's going on?
What's going on? But it's hard because if you come from a low, you know, socioeconomic background, these foods are cheaper to buy.
Yeah.
You know, so people are struggling. So it's like, how can you really balance when it's like the bad food is what's cheaper and more affordable? Because they're making these foods cheaper for people to buy. Yeah. It's a lot easier. People are lazier to cook, you know, so this is a rising problem. And if you're at work, you don't have any food, you want to go buy something like a microwave meal. Yeah. It's just very easy to pick up, isn't it?
Yeah, it's very easy and it's cheaper, right?
Yeah.
Like, it's cheaper than I can't remember. I was in church one day and my friend was like, you know what, Paul, I'm just going to have organic food from now on because I've been reading all the stuff online. So I go into like Asda the next day and I'm like, oh, you know what, let me just get some organic eggs. And it's like £6 for a pack of 6 organic eggs. And then, you know, like the farm eggs that are like the K10s is like, I don't know, £2 or something.
Exactly. So it's like a lot.
There's definitely like a difference in the price when it comes to organic food versus, you know, non-organic preserved food.
Yeah. But back home, I guess we're doing something right in terms of we're cooking our food back home. We're not, you know, there's not a lot of like, I don't see when I go to Nigeria, I don't see microwave meals, you know. So I think that's a plus of what we're doing back home, but not over here. With colon cancer, it is actually the second most common cause of death in the UK. So can you give us the 3 warning signs for colon cancer?
They're a bit vague, but they are there. Like if you are aware of them, then it's something that you can take again to your GP and say, look, I've noticed these 3 things or these few things going on. You know, can I be screened? And so the number one thing is there a change in your bowel habits? You know, and it's a bit of a vague question because what is normal to you can be normal to someone else, right?
Yeah.
So someone could go like 3 times a day and that's normal for them. Someone could go 3 times a week and that's normal for them.
Yeah.
But has that changed for you? And has that change lasted longer than 3 weeks? Right? Oh. If it's lasted longer than 3 weeks, then it's like, okay, something chronic is going on here.
Okay.
I need to get this checked out. Rather than, you know, oh, maybe I've just eaten some spicy food the last 2 weeks. And the other thing I would say is bleeding. Right? I'd say bleeding from that passage is something that a lot of people are very embarrassed to talk about, even with their GPs. And again, it's not something that should be happening. There are many reasons why you have it. And to be honest with you, just because you have it does not mean you have cancer.
Okay.
But it's one of those things that if you do have it, it means that there's something in your body that, isn't right.
Yeah.
And should be checked out. So that's just the second thing. The third thing is what I call group B symptoms, or symptoms that aren't specific to any type of cancer, but generally, if you have cancer, you have these, which is weight loss, fatigue, anemia. And when I say weight loss, I mean unintentional.
Yeah.
Right. So you can't account for it at all. Those would be the kind of things I would look out for. So you combine all of those things together and you notice them in yourself for a period of like 3 weeks, then definitely speak to your GP.
Oh, okay. That's noted. I think we should definitely look out for that.
Yeah.
And you mentioned the point of like people going different times, because I, for example, go once a week or twice a week. But then I have friends who are going like 3 times a day. And I'm like, but would you say their gut is better if you go more often in the day? Because I don't know. I feel fine even if I go once in a week, but someone else would feel like that's too much. They're constipated, like almost.
That's a good question. So I spoke earlier about like trying to detect cancer from the gut because of different signatures, right?
Yeah.
And so everyone's gut has its own signature of microbiomes.
Yeah.
So microbiomes being like the different bacteria, the healthy bacteria in our gut, right?
Yeah.
And so everyone's is different. There is like a common set of bugs that we do have that you're meant to have, but everyone's like distribution of those bugs is quite different. So that means there's a different signature of stuff. So depending on who you are and who your mum and dad is and what their genetics are, there are certain foods that you can eat and they'll just go right through you. And there's certain foods that you eat and they'll just like stay longer. It doesn't necessarily mean your gut is healthier. It just means that, the way you process certain food types is different. And a great analogy for this would be alcohol, right? So there are certain people's liver that just can't hack it.
Yeah.
You give them a shot of something and then their faces are red or and they're all tipsy. And then there's some people, you give them like
I could
a
go
bottle
5 shots.
Right.
Yeah,
so
I'm good.
both livers are working fine for their normal functioning body.
Okay.
Right? They're both livers, they're healthy.
Yeah.
So it's not really about their health. It's just about, the signature of enzymes and microbiome inside of the gut.
Would there be signs that you have a bad gut microbiome?
Yeah. Sometimes you get some symptoms. Like I would say, if you're always bloated, always bloated type,
I feel like I am.
You see a GP yet? No. I think bloating is a difficult one, but definitely always bloating because it just means that, and it's interesting because something like what's it called, IBS, right? It's a very common phenomenon. A lot of people have IBS.
Yeah. And
one of the things that isn't actually prescribed in the NHS for IBS is something called fecal transplant, right? Where there's a tablet you can take and it replaces all the microflora in your gut. It's not, but it's quite expensive.
Okay.
But it's one of those things that actually it's known to have a good benefit for IBS. So I would say definitely the change in your microbiome can produce a lot of bloating. And so bloating is definitely one of the signs of having, a bit of an impaired health. It doesn't mean your health is bad. Again, it doesn't mean you have cancer, but it's just something to be aware of.
To be aware of. Yeah. That tablet, is that something you take every day or is it once in a month? I don't know.
It'd be like over a month. You take it once a week.
Oh, okay, fine. Might need to try that. And another fact I've seen is that people born in the 90s are twice more likely to get colon cancer compared to people born in the 50s.
Yeah.
So apart from the processed foods, are there anything that we are doing, as a young generation that is, increasing our risk of colon cancer?
I would say that statistic though has another variable to it, which is that compared to maybe 20 years ago, we have higher screening rates.
Oh,
so because we're screening more people, it's easier to detect cancer earlier, right? So that's why it's easier to see it then than it was before. But I think a lot of this all links back to the processed foods, and the reason why I say that is because people born in the 90s compared to people born before then, smoking was probably more prevalent before the 90s, right?
Yeah.
There was a bit of boom of smoking, and maybe obesity is more prevalent now. But and diabetes probably was even more prevalent then in terms of its control. Now it's better controlled.
Yeah.
But one thing that has consistently increased is just the consumption of processed foods. I'm not even like a processed foods champion, right? But it's just the one thing that you can look at. If you treat these patients a lot and you look at their lifestyles and you ask them, like, you know, what their dietary intake is, and you just see it in the areas as well. This is the one thing that is consistent, and you don't see it in other non-Western societies.
Yeah. That only 5 to 10% of colon cancer is genetic.
True.
So that means 95% of people don't have a family history.
Yeah.
And that's alarming. So it's like, it's not even a family history that's driving it. So a lot of it is to do with lifestyle then. Yeah. So it's like, what can I do to stop myself from getting bowel cancer? Is there anything I can do? Obviously, stop the processed foods.
Yeah.
Is there anything else? Is alcohol contributing, or, you know, exercise, things like that?
The best thing that you can do, because not everything is in your control.
Yeah, definitely.
And, you know, genetics does play a part, even if it's a small percentage. But the best thing you can do is to control the risk factors. And so the known things are what, like you said, smoking.
Yes.
If you quit smoking, or if you struggle with it, then definitely reducing smoking will help. If you are someone who is quite sedentary, then being more active is definitely good for you, because by being more active, you increase your metabolism. And by increasing your gut metabolism, you increase the transit time of stuff in your gut. So these carcinogens that we eat don't spend as long in your body. So definitely staying active is good. Drinking is actually associated with it. But I think, you know, all things have to be done in modesty. It'd be more about drinking too much, or people who are alcoholics.
Yeah.
And then just being aware, you know, if there's someone in your family who has had colorectal cancer that you know, then it might be worthwhile, especially if it's a first degree relative, so your mum or your dad or your brother or your sister, going to speak to your GP and ask to be screened a bit earlier.
A lot of the research as well is suggesting that our diet lacks a lot of fibre.
Yeah.
And that is contributing to bowel cancer.
Yeah.
What is the link between, you know, low fibre and bowel cancer?
There is a link, right? There is a link. There is a study called EPIC, and I think it's a meta-analysis. So it's like one of those studies that look at all the different reviews that there are out there.
Yeah.
And it's, I don't know who's done it. I think it's, if you just type up EPIC fiber meta-analysis study, and it tells you that for every maybe 10 grams of fiber that you add to your diet daily, you reduce your risk of colorectal cancer by 10%.
Oh, wow.
Right? So there's definitely a link, first of all. And in terms of why that link has a lot of validity to it, is the idea is fiber itself, it acts as a supplement for the bacteria in your gut. So it provides something called short-chain fatty acids, which is what the cells in your gut need to survive. So it gives your gut the health that it needs. The other thing it does, it promotes the transit of food, especially like the unprocessed stuff, to go in a bit faster. So they don't spend as long in your body. So over time, over the years, you know, if you're having more fiber in your diet, then definitely, you know, you're going to have a better gut health. So it's been like, I guess, looking at all the studies, there are certain foods that have high content of fiber in them that are like, are definitely going to reduce the risk.
As a surgeon, are you eating 30 grams of fiber a day?
Probably not. But I will say, because I was looking at, when I saw this study, I was like, okay, what are the foods that has fibers in them?
Yeah.
And there were things like legumes, sweet potatoes, lentils, black beans. But then I saw plantain.
It's got fiber in it.
I love plantain. So I was like, okay, fair enough. I'm eating plantain like 4 times a week. So there are things in there that, of course, you know, you can, you know, there's other things. There's chia seeds, and I know that's quite popular today. But if you looked it up online and just thought, okay, what are the foods that are highly rich in fiber? There will be something there that you actually enjoy. It's not, you know, purely just all these grainy foods. Yeah.
Are the types of fiber also, like, do they come into play? Is there different types of fiber, or is it just fiber as a whole?
There are different foods that give you fiber.
Yeah,
that's very true. And so, for example, in this study that I cited, fruit fiber actually wasn't linked as much as cereal fibers. Yeah, so that you're right to think that as well. So it does, you know, it does take a little bit of self-education to know what fiber is good for you. Whole grain bread is another good type of fiber as well.
Yeah. But foods like white bread and white rice, they don't have as much fiber in them.
No.
Fine. And I think that's what we eat.
Yeah, I know.
Like it's always white rice and stew. If there's not, and when I deep that in that diet, there's not really much fiber in like a white rice and stew plate.
Yeah.
But with our foods, like things like egusi soup or soups that we make, they do have a lot of leafy greens in them as well.
That's a good point. So what I would say is that, okay, fine, they're not heavy in fiber, but actually one advantage is they're not as processed. There's a Nova classification of how food can get processed by this Brazilian guy called Carlos Monteiro or something. You've got unprocessed food, which is like class group 1, and that's your legumes, your seeds, your milk, what else? Your vegetables and your fruit. Then you've got stage 2, which is stuff like yogurts, butter, pasteurized milk. So it's only gone through like one layer of processing. Then you've got like group 3, which is, and the point I'm trying to make is a lot of the foods that we eat are usually group 2 or group 1. They might not be high in fiber, but usually if you take them back to their root, particularly back in Nigeria, for example, it's always stuff from the farm, or the poultry. So group 1 and group 2. When you get to group 4, it's the ultra processed stuff that's gone through like maybe 3 layers of industrialization. That's the stuff that I think is really high in the Western diet.
Yeah.
So while we don't have a lot of fiber, actually we're not eating a lot of processed food.
Yeah. Can I add fiber to my food? So are you in support of like fiber supplements and stuff? Because
I think so.
I've been putting on like psyllium husk powder over like sometimes my food just to get that extra bit of fiber. Is that the same? Would it be the same or enough fiber, or good quality fiber as a supplement?
I think you can add it to your food. And the reason why I say that is because the average intake of fiber in the UK is somewhere between 10 and 16 grams, whereas the recommended is 30 grams.
30.
So we are deficient of fiber the same way we're deficient of vitamin D. So I think you should definitely add it. It's always a good idea to do it.
Yeah.
In terms of what fibers to add to your food, you'd have to do a bit more research as to what's the good type and what's the bad type.
Does sugar have a part to play in this rise in colon cancer as well?
Sugar's group 1.
Yeah.
Sorry, sugar's group 2.
Right.
So in terms of it being processed, no, unless you're eating like corn syrup and stuff all the time. But what I would say is sugar has, it has a direct link to diabetes.
Right.
So if you have a lot of sugar all the time and you're not controlling it, you don't starve from time to time or fast, then you have a higher chance of getting diabetes, right? Because you increase your resistance to insulin.
Okay.
And so people with type 2 diabetes definitely have a higher risk of certain cancers. And there is links to things like colon cancer.
Colon cancer. Yeah. Oh. And you mentioned the corn syrup thing.
Yeah.
Where's that mainly found? Is it in the Fanta and stuff?
Yeah. So in a lot of your cordials.
Cordial?
Yeah, cordial.
The sugar-free ones?
Yeah, sugar-free ones. That's why they're sugar-free.
Bro, I need to stop this sugar-free thing. Like, I just think when it says sugar-free, I can just have it.
Yeah. You see it all in the hospital as well.
Yeah.
Every vending machine is like...
So is your
Coke
argument
Zero.
that we should have sugar then? Because then, I'd rather have something that's better for me. So if sugar's better than corn syrup...
Well, it depends what you're trying to...
achieve.
Yeah, it depends what you're trying to achieve, right? I don't want diabetes, so I'm not going to have any sugar. Right, so corn, fine, I'll have Coke Zero, for example.
Yeah.
But also, if I don't want to have too much Coke Zero where I'm just having processed drinks all the time, and that's going to increase my risk of another type of cancer. So it depends really what you're trying to achieve. Personally, I drink a lot of water and tea, right?
Okay, yeah.
And maybe like once in a while, I'll have like, I don't know, an apple juice or something. Yeah,
fine.
Or a malt. But it's all about moderation. I think anything really can kill you if you have too much of it.
Too much of it.
Yeah.
See, I could have a Fanta every day that's because it's sugar-free. So I think maybe I'm just going to cut back on that because I actually think I can get away with it.
Yeah.
But now, hearing what you're saying, I'm like, no. The patients you're seeing with colon cancer, what do they look like? Like, what is it? What are we talking about in terms of prognosis? I see a lot of patients have stoma bags as well.
Yeah.
What does that, treatment look like for them?
Yeah, that's a great question. Because I don't think people know, right?
Yeah.
It depends on when you detect it.
Okay.
Right? That will really determine 1, your survival, and 2, your treatment course, right? So let's say you've got 4 stages of colon cancer, right? Stage 1 to 4. Your GP says to somebody, the patient, we found that you've got stage 1 cancer after all your tests.
Yeah.
Stage 1 cancer generally has a 90% 5-year survival chance.
Okay.
So that means there's a 90% chance that you will survive beyond 5 years.
Okay.
Right, if you go engage in treatment. And the treatment for that typically is chemotherapy.
Okay.
Right? It's just chemotherapy.
Chemo.
If after chemotherapy there's still some cancer, then they can do surgery. It usually is resectable to surgery.
Yeah.
Then you've got stage 2 cancer, which is like it's confined to the bowel, but it might be spreading a bit and touching other organs next to it. It has a 5-year survival rate of about 75%.
Okay.
Right? Again, the treatment for that predominantly is chemotherapy, then surgery, then more chemotherapy.
Fine.
Right, and that's what that looks like.
Yeah.
When it comes to stage 3 cancer, it's a little bit different because it means the lymph nodes are involved.
So it could spread.
Yeah, so it's starting to spread. And so when the lymph nodes are involved, you start to think, okay, this has a lot lower survival in terms of 5 years. I think it's probably around 45%. And the treatment course is usually a little bit more complex, right, with chemotherapy, and may involve in the interim a stoma, right, which is what you just asked me. And a stoma is essentially it's a surgical procedure, and it's done as an interim to divert the passage of your bowel contents into the bag away from the cancer. Right?
Okay.
And the reason why you do that is because as the cancer grows, it causes an obstruction.
Yeah.
Right? And if it causes an obstruction to a point where, your bowel can perforate or your bowel does become, ischemic, which means it loses blood supply, you are not amenable to chemotherapy. If you are not amenable to chemotherapy, that basically means that you can't be treated. And so your mortality risk goes from like 45% at stage 3 to almost like 95%.
Wow.
Right?
Yeah.
And, stage 4 cancer means it's spread to distant organs. And generally, there is some resectable, which by resectable I mean surgical treatment for that, but most of the time it's palliative. So that means it's done to make the patient feel better rather than to cure the patient. So in terms of, how this translates to the general public, it's a case of wanting to engage in screening, programs a bit earlier so that you can detect these things at an earlier stage rather than a latter stage. And I think that's the difference in detecting cancer today than it was 20 years ago, right?
Yeah.
So screening is more prevalent, and so more people are able to see that, I've got cancer, but actually this is stage 1 or stage 2, and I can, start to have treatment for it.
That's treatment, yeah. And I think obviously the bowel cancer screening is currently for over 50s.
Yeah.
But I do think given the rise in like bowel cancer now in the young people, don't you think it should be decreased now? Because I'm thinking if people as young as 25, 26 are getting bowel cancer, screening should be maybe 25, 30s now.
Yeah.
Would you say?
Yeah, true. Well, yes, and I agree with you.
Yeah.
I agree. This is why I think the screening process should be a bit more simple.
Yes.
So the screening process isn't straightforward. It used to be 60. It was only recently got chopped down to 50.
Yeah.
And even in some catchment areas of the UK, they will only send you an invite at 55, right, or 60. So it has changed. And I do agree, it should come younger. And if anything, it should be accessible to anyone on request. Like, if you're under the age of 50, so let's say 30 to 40, and you are, you're suspicious, you should be able to just go to your GP and say, look, I'm worried I might have bowel cancer, can I be screened for it?
Yeah.
Because the reason why I mention it that way is because if we just open screening to everyone from a certain age, what you have is complete depletion of resources. I don't think we have the capabilities in the UK to screen everyone. Yeah.
Because I've seen that as well on TikTok. Most of the people I've seen, patients I've seen who are sharing their story are being diagnosed at stage 3. So I'm just wondering how is it, comes so late to when, these patients are finding out at stage 3?
That's probably one of the biggest shames of the system, to be honest with you. I don't want to blame the patients, of course. There is a societal stigma attached to some of the things, the process that you have to go through when it comes to screening. Particularly the first stage of screening, right, is something called a fit test.
Yeah,
you've heard of the fit test.
I've heard of the fit test, yeah.
And the fit test is you have to take a sample of your stool and submit it to lab.
Yeah.
But nobody wants to take a sample of their stool. That's like, it's like, oh, why would I want to do that?
Yeah.
I'm a doctor and I still say, oh, why do I want to do that? I don't want to hold the sample.
Yeah.
But it's societal stigma that we need to override if you want to, know that there's something that could potentially lead towards the end of your life, right?
Yeah.
So I think that's the
100%.
thing. It's about balancing out, the stigma versus the benefit. And it's not just that. The other thing is colonoscopies. So colonoscopies is a procedure that even when I think of it, I'm like, I would never do that.
Yeah.
Right. But it's something that has to be done if there's a suspicion of cancer. And I know my dad, for example, he's had a colonoscopy, right? He is embarrassed about any female being in the room. So he doesn't even let a female endoscopist do his colonoscopy. And for those who don't know what colonoscopy is, it's like it's a flexible camera tube that it has a camera on the end, and they put it up your back passage to try and detect if there's any cancers from the inner lining of your gut.
Yeah.
Because all cancers of your gut start from the inner lining and then spread outwards.
Yeah. But a lot of people wouldn't want to do that. It's quite vulnerable. You're kind of laying on your side, having a tube through your back passage. It's not ideal.
I would preface it with you are given sedatives and analgesia, so they do give you some strong stuff. But so most patients actually just kind of fall asleep during it.
Yeah.
But again, it's like undignified.
Some research is also suggesting that bowel cancer awareness is higher in white populations. And studies are showing lower rates of awareness of bowel cancer symptoms in ethnic minorities, especially in like the Afro-Caribbean and Somali adults. I'm just wondering why do we not know, that there's screening available? Why are we not more aware of these symptoms, in ethnic minorities?
Yeah, that's very true, actually. Some variables you can point to that do make sense, like language barriers. Right.
Yeah.
There's a huge language barrier. For example, people, reading the program for the FIT test, it's only available in I think 5 languages or maybe 10 now, as of last year. But before then, it was only available in English and French or something. So that's one thing. The other thing is, I don't think there is an active. Well, first of all, in these, for example, Black populations and minority populations, they tend to reside more in areas with high economic depravity, right?
Yeah.
So in these areas, or low socioeconomic index areas, and so in these areas, there isn't probably enough done to promote these screening programs.
Yeah.
Right? So if you go to an affluent area, for example, you're getting invitations through the letterbox to kind of join the FIT program.
Yeah.
But if you go to somewhere like, I'm pretty sure I was driving through Deptford Bridge, there is no one putting out these FIT leaflets inside people's doors.
Which is bad, isn't it? Because I think we all have access to the same NHS. So why is it one area is deprived over another? People also get scared to go into the hospital because they're scared to be ignored.
Yeah.
They're scared to advocate for themselves.
Yeah.
So how would you kind of advise someone if they feel something's wrong to kind of go in there and get it checked?
Patients I feel the sorriest for are the ones who come in and, they're young, they're about 45 or something, and they've just been ignoring it because, they just thought it was a tummy ache. And then, you do a scan on them and it turns out they've got stage 4 cancer. And, it hits them like, oh, I've been ignoring it. And, I think we can tell ourselves that, nothing is wrong, but we never really know until we've done all the tests.
Yeah.
And I think the best thing that you can do is just phone your GP. You don't even have to go for an appointment. You just have to speak to a specialist,
Yeah.
The moment when you have a conversation with someone, it's easier. If, someone has a conversation with me, I can always be honest about, from what I know, whether I think this person should be screened or not. Engaging with some of the, the screening programs that are available, not just for colon cancer, there's other prevalent ones like breast cancer, which I think starts young now.
Very young, yeah. There is a fear that if, I go to my GP and I tell them that I have these problems, my GP's not going to listen, or my things I've said are ignored.
Yeah.
And I think that fear of okay, I'm going to the GP, but I've been ignored anyways.
Yeah.
Yeah.
I would say, right, and a lot of my peers would probably kick me for saying this. I would say go with education, go with the information so that you can challenge the GP. Not to be challenging or contrarian, but rather to say, look, I've been experiencing these things, and actually, from what I've learned, this is what I think it could be. Can you prove this wrong? Can you show me that I'm not overthinking it?
Yeah.
And it's their job to really, because if you look at the actual root word of the title doctor, it comes from the Latin word docere, which means to teach. So their job is to really like go, okay, what you said actually makes a lot of sense. I'm gonna, refer you onto this. Or they go,
Yeah.
Maybe that's not the case because it could be this, this, and this.
Yeah, like challenge it a bit. Yeah, because I think a lot of the time people don't have medical education, so they come in without knowing anything and just go blindly. So it's good to kind of do that bit of research beforehand as well. Thank you so much. That was really, really helpful.
That's okay.
So given the rates of, rising colon cancer in the young people, what would you say is your last message to the young people about avoiding, this colon cancer rise, and also not helping them to feel less scared right now? What would you tell them?
I would say to them that as a clinician personally, it's, it goes beyond just trying to do the job. We are quite empathetic and understand not just like the stigma, but also what is required for you to go through the journey of either detecting it or treating it. And so, your dignity will always be protected. But beyond just being protected, I think, you're in a place to learn and to use your experience to help other people as well. So, I think most patients who come to my door, even if I do any type of clinic, stigma kind of goes out the window, and there's a lot that goes into trying to make you feel comfortable, to being tested, to being spoken to, and to being treated. And I don't just speak for myself; I speak for probably every single trainee and consultant that I've worked with throughout the entirety of my career, which is sort of short, it's 10 years, but I do think, the way medicine is moving, a lot of the doctors actually becoming a lot more empathetic and engaging with a lot more of the holistic care of the patient rather than just like the condition or the disease.
Right. Thank you so much. Usually before we end every episode, we have a thing where we ask everyone who comes on here, if you had 3 chances to live, and you're a surgeon, what is one thing you're going to do every single day, to be healthy?
I'd run every day, run every morning.
Okay.
I'd do a 5K run every morning.
Really?
Yeah.
Why?
Because just to stay healthy, right?
Yeah.
Because what it does is it taxes the body, right? And I do it before anything I start. So how there's this craze about intermittent fasting, right? People intermittent fast.
Yeah.
And the whole idea is you starve your body of all the nutrients, and what the body does is it uses the bad cells and gets rid of the toxins. I think running does that at an exponential rate, right? So what you would get in 18 hours, if you did it you could get in half an hour run, with the right intensity. And so I'd wake up every morning and I'd run at 5 a.m. or something.
Yeah. I'm going to try that. I'll see what I can do. Thank you very much.
Yeah.
Should we have a shot?
Go on.
So this is super greens and a lemon shot. Fine. Should we cheers?
Okay, let's go.
It's
Have
sweet.
you had this before?
No, I haven't.
It's nice.
It's nice. Yeah. I don't think it's like even a shot. It's quite good. Thank you so much, Dr. Paul, for coming on to EZE Speaks.
That was a pleasure.
I hope you guys enjoyed this episode. Can you tell us where we can find you? Are you on any socials, or how can we chase your project that you're doing as well, your PhD?
Oh yeah, so my PhD is with the Hanna Institute. It's at Hammersmith, led by Professor George Hanna. But outside of that, I'm not that active on socials, but I do have an Instagram. It's called Pablo's Table, just one word. I'm always accessible. A lot of my friends message me and they're like, yo, we've got health concerns. I need to speak to my GP. Can you write what I need to tell him? And so I always write stuff for them. But I'm always open to helping people out with their health generally, So yeah, I am very approachable and contactable.
Perfect. Thank you so much. Welcome. Thank you so much, guys, for listening in. Please make sure you give us a subscribe, follow, and leave a comment on something that you have learned. I hope this was enjoyable for you, and we'll see you in the next episode. Bye.